Students seated over the back can please come fill up the front seats, please. We'll try to fill up the first 3 seats up front. A very good morning and a warm welcome, ladies and gentlemen, to our monthly clinical pathological conference, Faculty of Medicine, UKM. And this month, it's been hosted by the Department of Emergency Medicine. Our conference topic today is Dying in Care, Facing the Inevitable. Before we begin, allow me to introduce our 3 distinguished speakers for today. We have with us Dr. Munawar Hatta, Consultant Emergency Physician and Medical Lecturer, Department of Emergency Medicine, Hospital UKM. Dr. Khazrul Nizar Abdul Kader, Anestesiologi and Critical Care Specialist, Hospital University Bangsa Malaysia. And Dr. Azizan Zakaria, Internal Physician and Palliative Medicine Specialist, HUKM. Ladies and gentlemen, some housekeeping notes. The QR code for the CPD and attendance will be projected on the screen towards the end of our conference. We will begin our conference today with a case series presentation by Dr. Munawar. Doctor, the stage is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Very good morning, everyone. Thank you for joining us today. First, I would like to share with you a number of cases that we have encountered. These are real cases. For the purpose of maintaining the confidentiality and for family requests, we don't share the details, the names and the pictures, but I think it suffices to just go through the details as per slides. The first case was a young man, a 19-year-old motorcyclist, hit by a car, and the helmet was off. He was found unresponsive in the drain after hitting a road divider. It's one of the main highway nearby. So when the ambulance arrived, they noted that there was no pulse. GCS was 3. CPR started, brought in to our hospital. Along the way, ROSC achieved return of spontaneous circulation. We noted that he had ENT bleed with a huge scalp hematoma. Pupils were sluggish and dilated. CT brain showed extensive ICB, very tight brain with a skull fracture as well. We started on inotropes, but the BP was lowish. There were signs of coning, and unfortunately, patient did not survive. Was with us for a few hours, and when the family came in, they were, of course, distraught, and it was a very challenging time for us to tell that their son, both parents were there. That the sons were dying at that time. So we had, I think, about a couple of hours before we pronounced death. The second case is a man, a smoker, known case of hypertension. He was in the office when he complained of chest pain, when the colleagues noted that he fell. He was sitting in front of the PC, and then fell on the chair. So when the ambulance arrived, they started the CPR then. One of the colleagues started. brought to ED, noted a shockable rhythm, managed to revive for a while, but not sustainable. Full 3 inotropes on board, but BP still lowish. Intermittent ECG showed ST elevations, and unfortunately, after prolonged resuscitation, patient was pronounced dead. The daughter and the children came from the school, so we had that opportunity to call in the family members to be with him at the last moment. This was a case that happened during COVID time back in 2021, 2021 end, I think. 37-year-old female. She was obese with diabetes. She had been complaining of cough for a week, and on arrival she was very breathless. She was had a temperature, and SpO2 was only 70%, 72% on air. She was confused and immediately intubated for pending respiratory arrest, but soon after arrested for a number of reasons. CPR commenced, but unfortunately patient did not survive long. She was with us for, I think, close to 2 days. Remember the multiple CPR cycle. After I think about 1 or 2 shifts, asystole again. So ROSC achieved, but at that time it was difficult because no family members were allowed to visit. I remember those time, and we had multiple video conferencing using iPad that was donated by the public, where we showed the patient's condition. I remember clearly the last moment before we intubated the patient. He was on high flow mask, pending respiratory arrest. We put on the iPad, did a video call with the family member, and they were saying, we'll see you again and whatnot. But soon after he collapsed. So cause of death is COVID stage 5. Before I pass to Dr. Khazrul, just to recap the kind of cases that we encounter. We know that not all patients survive when they come to hospital. Statistically, about 5% of ED patients did not make it. Either they pass away in the department, or they managed to go up for a while but pass away later on. Some of them were brought in dead, but even then we attempted resuscitation. So we had this about 1 or 2 hours period where not only we manage patients that arrive to us, but also the family members. For every single one that is dying, we know that there are many, many more potential patients among the family members that are also affected. So today I think we're going to discuss how we manage the kind of challenges that we face, and hopefully we can somehow venture into this the fourth domain of a holistic approach to health. We know that we have the physical, we have emotional, we have the social, but the psycho-spiritual sometimes is lacking. So I think that's the theme for today's CPC. I would like to call upon Dr. Khazrul to continue with the presentation. Thank you.
Okay, thank you, Dr. Munawar and Department of Emergency for inviting me. Good morning, everyone. I see most of our attendees medical student, I believe. So actually, this is a huge responsibility for me to introduce you this topic. Actually, end of life care topic, not by standard, is a one-day course of talk, but I will try to make it short and sweet so you don't miss understanding what we're talking about. So from the case study that Dr. Munawar presented to us just now about 3, so you see the ED department try their best to help this patient, but at the end of it, the organ cannot take it, and patient goes into the not responding to the treatment, and the dying process happen. So here, this is our role. It's not intensivist, the critical care specialist responsibility to manage the dying patient, but we as a doctor as well have to be responsible to recognize the dying patient and to give appropriate care. Okay. Okay, so basically, in the advance of technology, ideally, most of the critical ill patient or terminal ill patient should be managed in our intensive care unit. But I think some of you understand or look at our bed occupancy rate is very high and limitation in the number of bed. So most of our patients in a renal ICU, in the cardiac care unit, or even in ward or ED department itself. So most of them come with a very ill condition, and suddenly they develop multi-organ failure and goes into the terminal ill condition that the survival rate cannot be expected but within hours or less than 24 hours. Okay. So despite the development of new technology and the improvement of care, death rate in the intensive care unit or in other units remain high. So I will quote about 20 to 35%, or maybe perhaps higher in some of the geographical region. But in Malaysia, about 20 to 30%. And when the organ dysfunction of critical ill patient does not respond to treatment, and the goal of care cannot be achieved anymore, or when life support become to be non-proportional to expected prognosis, physicians should provide an acceptable death. So from the case just now, we don't simply, okay, I would like to emphasize again to all medical students, we not just let the patient die, okay? We give the best we can do for this patient as maximum as possible, as acceptable as possible. And when the dying process happens, so we have to accept the death is inevitable. So we have to allow it goes naturally without force to the patient, to the family itself, okay? So the care is still continue. We don't abandon our patient, okay, medical student? Because I don't want you guys misunderstanding our topic today. We just let go the patient. We don't let go the patient easily, okay? So when the dying process has set in and death is imminent, a technological prolonged dying process take away the serenity and dignity of death, and nature should be allowed to take its own course. So depending on the cultural aspect or yourself, how you perceive the good death itself. Okay, there is a guideline talk about the what is good death, but I think it's more like individual and cultural perception on the what the definition of good death. Some of the patient want to be with family, some of the patient want to be out from the hospital to be managed in the ward, in house. It's depend on them. Okay. So basically, what is an end-of-life care? So in the end-of-life care is an approach to a terminally ill patient that shifts the focus of care to symptom control, comfort, dignity, quality of life, and quality of dying, rather than treatment aimed at cure or prolongation of life. Yes, end-of-life care and terminal care is a subset of the palliative care, which is Dr. Azizan will elaborate later. But for this topic today, we are going to give a care for those who expected to die within hours or less than 24 hours, like what the Dr. Munawar explained just now in the case report. So it's not easy. So there's a lot of dilemma dealing with the end-of-life care. First, the clinician should recognize when a patient is dying, and the decision is very complex and maybe emotionally distressing for Dr. Munawar itself just now, okay? And we have to be honest about the diagnosis, uncertainty, and we have to make a clarity about the communication. Nowadays, you have to communicate clearly to all your team, to the family member, so everyone should be in the same area of flow of thought, okay? And you need to be balanced about the potential benefit of critical care against the burden, and you have to be able, you should be able to analyze both quantitative outcome measure and qualitative aspect of patient value. And if you can't perform all of these method to manage the patient during the end of life care, it will lead to the misunderstanding and conflict. The misunderstanding and conflict can happen not from the family member, but within the caregiver itself, within the doctor, within the nurses itself, okay? Because we are not in the same radar, okay? So, yes, I know some of us, the doctor itself, that we are very afraid to talk about to letting your patient go, okay? You are very afraid, okay? Because we afraid the legal and the ethical concern. So, decision for end of life care is we use the ethical consideration of the bioethic, of the autonomy and everything, the fidelity, everything. So what the legal say about this end of life care? So I quote from the MMC Code of Professional Conduct 1897 and revised in 2019. Any decision by a practitioner to prolong life through life support or other measure or to terminate such support must be made in the practitioner's best professional judgment in consultation with colleague and next of kin. And of course, in Malaysia, we don't support euthanasia and assist suicide of patient or passive euthanasia. And a practitioner may be confronted with a living will or advanced medical directive. In Malaysia, we don't have a documented advanced medical directive much, but most is verbally. But actually, it's good if you have a advanced medical directive verbally, so you can have an idea about the direction of care. Okay. And another one is a code of medical ethics. So what they say about dying patient where death is deemed to be imminent and where curative or life-prolonging treatment appear to be futile, ensure that death occur with dignity and comfort. So you can see how many frequent the word of dignity and comfort used in this code of ethics. So you need to be balanced, risk, benefit, risk and burden, principle of medical ethics, and how law relevant to concept and capacity shape for the decision making about the end of life care. And in Malaysia today, there's no local judicial decision on the matter available, and most of the time the end of life care treated as purely medical decision by the physician, and there's no case to bring to the court, Malaysian court yet in Malaysian. Okay. So how end of life care process happen in our hospital? So we are currently in developing a policy, but still in process. Okay, so the physician itself must be able to make a objective and subjective assessment. So we always say medical futility. Yes, even I myself even a bit difficult to use the word futility because I afraid to letting go my patient as well. So, but the most important is you have to identify patient who is dying with the medical support, everything. Okay, and then like I say, sometimes you use the word futility, but sometimes when you discuss with your colleague don't want to let it go. So you have to discuss. The multidisciplinary team discussion is very good. So you have to discuss among yourself what the best you can do. Is it maximum you can do? Although a patient is dying. Okay. So you need some experience and expertise. So not a medical MO to decide on end of life care. So you need a senior consultant to discuss about it. Okay. So you need a consensus after you discuss among yourself. So you need a consensus among all caregiver. All caregiver is a doctor, staff nurse, PPK, and everything who involved in the care of the patient, because it's an over responsibility to make a decision. Okay. So after that, you need to make a honest, accurate, and early disclosure of prognosis to the family. So the most important component of the discussion of a multidisciplinary team discussion is the prognosis of this patient. So you need to deliver what you have been discussed among yourself and deliver to the family member or patient itself. And you can see during the breaking the bad news, most of the family member will say something about hope. Yes, hope should be respected during the prognosis disclosure, but you must be give a realistic view should be maintained. Okay, if the patient is dying, so don't be scared to say the word dying. Okay. So after that, what you want to discuss with the family? So this is some of modality we are going to talk to the family member. So if patient not still on like non-invasive ventilation, we're talking about do not intubate. If the patient is very putile to the resuscitation, maybe not for resuscitation. maybe patient is a maximum therapy, we not escalate to anything, we holding life support or escalation order. So this is shared decision making, meaning that after you discuss everything, it should be reviewed again, the discussion. Some of the member, they are not accepting the condition, so don't let the patient the family member hanging. So review again their perception about what you are talking about, the prognosis. Some of the family member do not understand at all what you are saying. Maybe especially you are using medical jargon or something, or maybe they need some input from the other person. Okay. So the family discussion, you don't get a decision on the point. Okay, so you come again. Okay, this is same with transparency and accountability. So once you meet the family member, the caregiver, you have to document all the discussion, and you have to make sure consistency among the caregiver. So like I said, I met the Dr. Munawar or Dr. Azizan. So I said this patient is dying. So my plan is this one. So we agree on that. So next day we have someone else from other department. So they don't agree with me. So you, as a treating doctor, we have to have the same page about this patient. So if the patient is on the end of life care, so we have to carry for the end life care. Okay. So implementing the process. So once everyone agreed on the process, what we agree upon, so we're going to implement at the different level, from the ICU, from the ward, from the ED and everything. So it's depend what we agreed, not for resuscitation, and we go for it. Okay. And this is Dr. Azizan specialty. So what happened is, for example, in ICU, once we are patient, the family agree for the end of life care. So sometimes for the comfort symptomatic control, we refer to the palliative care team. They are very expert in the dealing with the dying patient actually. Okay. And for the after death care, it depends on the culturally appropriate and sensitive everything after the death. So it's dependent, we are Buddhist or Islam. So we lead to we give to the bodies responsible. And the most important thing is, I think we lack actually. Sometimes even me as myself, actually once the patient die, actually we just the patients die, but actually we don't know what happened to the family member. Some of them, they have a pathological grief. This is very sad for them to cope with the loss of the loved one. So actually we have to give a bereavement support for the family member. Okay. So at the end of it, actually as a hospital committee, we need to review the care process. We can improve any quality, maybe some quality assurance activity that to review to reflect our care provided. Okay. And I think with that, thank you.
So that was a comprehensive review of the gold standard, what we hope that we have in place. Obviously, there are not so ideal situations that we face every day. So I will share with you some slides on the challenges because of these limitations. In emergency scenario, most of the patients that comes in, they have different expectations. Some of them are quite fairly healthy, although they have some medical issues, but they woke up in the morning and write and say goodbye to the family and go to work, and something happened, and the next thing that the family know, that they were asked to come to the emergency department, and on arrival they were informed that their family member is dying. So such an abrupt flow of news, I think, presents a huge challenge, not only for us, the healthcare workers, but more importantly for the family members to accept. And for all cases, they would expect the family member to survive regardless of the situation. So that is the starting point. And how you address that expectation will then determine the grieving, as Dr. Khazrul mentioned, the grieving process that comes afterwards. We also know that in most cases it's a complex medical case. We have inputs from not only from emergency team but the primary team, whether it's neurosurgical for ICB, whether it's cardiology for extensive MI, or respiratory or an ID team for the COVID patients just now. So more importantly, we need to be on the same page when there is a multidisciplinary care. And the example that Dr. Khazrul mentioned just now, when the next day somebody else come in and reverse the DNR status, and that is one of the worst that we can expose the family member to, giving hope and take them away, and being inconsistent. So it's quite important for all the teams to discuss prior to breaking the news. The problem with emergency setting is everyone is busy. We are managing several cases at the same time. So what we see is when a specific team comes in, when they don't communicate with other team members from different discipline, then miscommunication occurs. And that itself is a huge challenge. Yes, preventable, but it happens anyway. The setting is not ideal. We know that emergency setting is noisy, with full of patients, different types of patients. Some patients, they are put on stretchers next to each other, and the family members are not allowed to come in for privacy reason. So this limited access actually does not help the process of preparing the family members for the imminent death. As much as possible, in emergency department, HCTM, we advocate for end of life care to be done in our observation ward, for a simple reason that it is more quiet, it is a little bit more spacious compared to yellow and red zone, and the access is easier for the family members to come in. But unfortunately, the observation ward does not have a huge number of staff, so we cannot place a patient that is on ventilator or NIV in observation ward. So there is no dedicated area that a dying patient can come in. If you see some other hospitals, especially abroad, they have a grieving area as well as the end-of-life care unit within the emergency department itself. So it is doable. We are in the process of renovation, the RMK project. By end of the year, we're going to move out from the current emergency department to a temporary place. Hopefully within 2 years, we have a new setting, which is hopefully more conducive for end-of-life care in emergency department. We also know that every single patient needs intensive care. Remember, this is critically ill patient, so logically it has to be a standard of ICU 1-to-1. In emergency department, it's 1-to-4 or 1-to-5. So we share the same staff nurse, that going to counsel the family member, managing the patient's ventilator and whatnot. Is the same staff nurse that is attending a new case that comes in. Of course, we work as a team, but still there are limitations, and we can't allocate a dedicated staff to see this aspect of an end-of-life care. We do also encounter different doctors coming in, telling same story again and again to the family members, and some of them, they are confused because different doctor telling different things. So this is where I mentioned just now that we need to sit down together, regardless. Sometimes doctors have ego, as we are human beings. We have some preference. We have some, dia panggil PL kan. Tapi for the patient's sake, just put everything aside. Put your ego aside. Discuss, what's the best for the patient, and be decisive. Many times we see a patient being reviewed many times, but without a plan, and we don't want that. In emergency setting especially, Similarly, in ICU care, I don't think we can afford any delay or indecisiveness. So we should do our best to resuscitate patient and do our best to make sure that patient have the highest chance of survival. But when the time comes that we need to decide to let go, we need to do it in a collective manner. I think Dr. Khazrul mentioned about collaborative approach. This is very important so that when we communicate with the family member, it sounds in tandem and there's no confusion with the information given. We also see that the family members, sometimes those that arrive early will get most information, and along the way some of other family members comes in and they also wants to know what's happening. So I tend to identify early on who are the so-called dominant figure in the family, the decision maker. So I will wait for these individuals to come in, and then we do a family conference. Unfortunately, our family conference is on the floor without table and whatnot. In other hospitals, they have very nice privacy with drinks and whatnot. Unfortunately, in emergency department here, we don't have that space. Every single corner is filled up with canvas and stretchers. So we just use whatever space, sometimes outside. Remember, there was a case of MRR2, yang jatuh runtuh, that dijambat, so-called major incident, where Datuk Razman as Timbalan Pengarah at the time came and did the family conference. So it can be done by any one of us, but he had to do it in front of the the ambulance parking, because there were about 5 or 6 families. 3 of them passed away, 3 of them survived. So a huge family conference. So just imagine the dynamics of challenges facing by the healthcare personnel when breaking the news. And among them, family members, of course, some of them have denials. They will negotiate with us. They will try to get a little bit of hope for us to prolong the resuscitation. But we have to be firm and compassionate, yes, but we have to be firm. The last thing we want to do is to give a false hope to a dying patient. Unfortunately, in our setting, we don't have this service, chaplainship. In other hospitals, in some private hospitals, they do have this. I spoke to Ustaz Rizal from our Pusat Islam. They have a draft of guidelines, but it has not been endorsed yet. So I was telling him that it's better for that guideline to be discussed with the stakeholders before being launched by them unilaterally. So and this is not about Muslims. We should also engage the other religions as well. We are fortunate here in emergency department. We have close communication with representatives from different religious backgrounds. Whenever we feel that there is a need to call them, we do have their contacts, and to their credit, they do come. They do come to assist family members. But some family members, remember, they are not religious, by the way. So we cannot enforce that every single patient should have spiritual support. So these are some of the challenges that we face, and to not to put the limelight to Dr. Azizan, but I hope that he can enlighten us how to manage these challenges that we face, not only in emergency department but also in other critical care settings such as ICU and the rest. Okay, Dr. Azizan, I invite you to continue. Thank you.
Okay, Assalamualaikum and good morning. Thank you, Dr. Munawar, for inviting Palliative Care Unit to the CPC today, this morning. I think this is a what we call opportunity for us to introduce our unit, because we are a very small unit.
So now we are in the CPC, so means that we can get more referral from the doctors or from the physicians, other unit in the hospital. Okay, now like Dr. Khazrul mentioned just now, I would say probably like 70% attendant. The audience today is mostly students, right? So what I want you to do is to remember the word that Dr. Khazrul used, letting go and giving up. Okay, if you can write that down and bring that home and try to Google what's the difference between giving up and letting go, because you know, in terms of end of life care, we're not giving up, okay, but what we do, we are letting go the patient because we have done so many things. Okay, now another thing is, like, you know, you guys probably will be asking us, why do you refer patient in ICU and this patient has been intubated, has been sedated, and the symptom has been well controlled? So why do you need palliative care in ICU, right? Because they can do this themselves. And then some patient in the ward, they are intubated, they are sedated, okay, they're sedated with midazolam, okay, and then the pain is controlled with opioids, okay, and basically the patient has no symptoms. Okay, the reason for referral is not only for patient, because we do look after the family member as well, the carers. What we do, we provide support, we provide psychosocial support, and then we sometimes offer them information, okay, especially what's going to happen, so that they can have a clear picture what's going to happen, and then they can communicate with the rest of the family member. Okay, so let me start with my first slide. So what is end-of-life care? So the term used to describe support and medical care given during the time of surrounding death, okay? So the main objective is to improve quality of life for those who has life-limiting illness in a way that we manage the symptoms and we provide comfort. Okay, so how do you provide comfort? This is when, you know, other three components are involved: the emotional component, the psychosocial, the psychological component, and the social component. Remember, total pain. Okay, everybody has total pain. Sometimes when we manage pain, we manage the physical symptoms. We don't talk about the psychosocial, and we don't talk about the emotional, and then we find it difficult to control the pain. And at the end of the day, we cannot control the pain. But once we touch about the psychology, the social, and the emotional, suddenly the pain is very well controlled. And the word total pain, again, it's a new word, and it's been created by a lady called Cecily. I forgot the surname now. Okay, so like I said before, we also provide support, emotional and practical support, and information to the carers, family, and friends. Okay, so how long is end-of-life care? It's different, it's individualized, okay? It could be days, it could be weeks, it could be months, or it could be years. Okay, when we said about years, that could be patient with COPD, okay? Patient under respiratory team, okay? They have symptoms, okay? They are dying, but you know, because the disease cannot be reversed, but they're not dead yet, okay? So this is when we look after them, we provide some support, okay? Since we are a very small unit, small team member at this moment, mostly COPD will be looked after by the respiratory symptoms, and then sometimes they may introduce what's so-called opioid morphine in order to control the symptoms, okay? Okay, so who can deliver end-of-life care? Everybody can deliver end-of-life care, okay? And then when the patient is at home, so the carer, the family member, or maybe sometimes they have jiran, neighbors coming over to look after the patient, okay? And so they can deliver end-of-life care. So for these people who has no medical background knowledge, so usually we will be a close liaise with them so that we can provide them what they need, all the information that they need, okay? Whatever they're doing are the correct things, so that they will not mislead and they don't feel guilty or not happy looking after the patient anyway. So, and again, end-of-life care is usually delivered in the way that the patient wants to be treated. or nowadays we call it patient-centered care. And for this to happen, okay, the patient need to be referred early. Why do they need to be referred early? So that we can have communication with the patient, so that we can develop goal of care. So we want to know how do they want to be treated, okay? And then, like I said, end-of-life care can be at home, hospice, or hospital. Depends on patient own preference, okay? You probably know, like, elderly people, 80s, 90s, and they bedbound, okay? And most of them, they don't want to come to hospital and they prefer to be at home in their own normal environment. And even they say, if I'm gonna die, I prefer to die at home peacefully. Okay, so symptoms. Okay, what's the most symptoms in end-of-life care that we encounter is dyspnea and pain. Okay, and we have this. We have a postgraduate emergency medicine postgraduate doctor who did a recent study called utilization of PCAS among adult patients who presented to ED, and in his study showed breathlessness is the main symptom for ED visit, and this is basically correlate with the previous studies which has been done anywhere else in the world. Okay, breathlessness is the main symptoms in end-of-life care, and followed by pain. Okay, systemic review on symptom prevalence in incurable cancer showed that pain is the second most common symptom with prevalence of 71%. So we manage this symptom using medication, and for pain, for breathlessness, most of the time we will use pharmacological called opioids, and there is a few other methods, non-pharmacological, such as open windows, nursing in a wide open area, or sometimes we may use a small fan as well. Okay, so maybe I think the reason why I put this slide, because I just want to medical student to understand what called patient-centered care. So basically, patient-centered care is any planning or any decision making, doesn't matter, this is like a medical management, palliative care management, end-of-life care management, has to be involve patient. Okay, so when you involve patient, you have to take into account patient individuality, the cultural and the religious needs should be in there before you come up with any plan. So, and this is how the patient want to be treated. This is what we call patient-centered care. So when we practice patient-centered care, the patient preference and values will be respected and recognized. Okay, so regardless of background, age, religion, religious or sexual orientation, okay, when we practice this, patients feel respected and they feel that their dignity has been valued. Okay. Any questions from medical students? Anything? Okay. So like Dr. Munawar said, right, and cases that he put it on the slide. This patient, they are okay in the morning, go to work, had an accident, somebody brought to ED, and now they are dying. Okay, so how are you gonna break this bad news to the family? How are you gonna tell them that the patient condition is worsening and not responding to treatment? How are you gonna tell them that the patient is deteriorating and high possibility that he will not make it? It's not easy. It's not easy. It's very challenging. Even for doctors who experienced doctors, this can be very challenging. Okay. Now it has to be done very, very properly, because whatever you said at that moment will be remembered by the family member for the rest of their life. Okay. So you are the messenger. Okay. You probably heard what people said: don't shoot the messenger. Okay, so whatever consequences, complications that are going to arrive from the communication, you are the one who has to face this. Okay, the family will remember you. You are the bad doctor. You are the one who breaking the bad news. Okay, so that's why it has to be done very, very, very properly. Okay, and another thing is that we don't want the patient, the family member, to experience what's so-called pathological grief. Okay, so breaking bad news. Okay. So is there a strategies for breaking bad news? Yes. Okay, there's four, so far there's like 4 strategies, but the most common one used in the hospital is spikes and ABCDE. So this is like, commonly used in the clinical settings. Okay, so spike developed by Robert F. Bachman and his colleagues in 1992, and the objective is to define or to deliver the bad news, which is the core element, and at the same time addressing it to the patient family, what is bad news, and acknowledging their concern and emotion. Okay, so the word patient here can be interchangeable, whether patient or family member. Okay, depends on who we're going to break the bad news is. So the spikes, S stand for setting, P stand for perception, I invitation, K knowledge, E explore, S strategy. Okay. So setting, set up an interview. So we need to set up an interview. So what do we need to do? We need to arrange a quiet room, a proper venue. Okay, so if you are a female doctor, make sure you have somebody to come with you, a support person, a staff nurse, a PPK, ideally should be medical staff or another colleagues of you. Okay, so settings, and then make sure you know the details very, very well. Okay, because we do not want during the interview, during the breaking bad news, you keep asking your friend, you keep asking the staff nurse, what's the BP, what's this, what's that. Okay, that doesn't look proper. So you need to know every single thing about the patient. Okay, and then switch off your mobile phone. Please do not let your mobile phone to interfere with the breaking bad news. Okay, and then you prepare emotionally. Okay, before you start the conversation, the meeting, the conference, have an idea what you're gonna talk. Okay, so don't just go there blankly, know nothing. Okay, don't know what to talk. Okay, so you need to have objective what you're gonna say to the patient, to the family member. Okay, and what's the objective of this meeting today? Okay, sit down, make yourself relaxed and comfortable. Okay, so that's very, very important. You have to be very relaxed. We don't want you look to be a bit nervous, okay, agitated, because this is a body language. Okay, it will make the family agitated as well. Now, perception. Before you start the conversation, you can ask the patient or the family member what do they want to know, how deep they want to know that's the current situation now, how serious it is. Okay, and then try to get opinion from them, try to get all the information from them before you start the conversation. Okay, and then after that you can invite them. Okay, get a permission from them to start talking about the patient, their loved one. Okay, and ask them how do they want you to explain to them. Do they want in details or they just want a superficial? Okay, so it depends on them. Okay, and if this is a bad news, okay, give a warning shot. Okay, signposted they call it. Okay, signposted. Okay, show something is not good. Okay, because you don't want to shock the family member. Okay, so tell them, what I'm going to tell you today, it's not a good news. Pause. Okay, silent. It's okay to be silent for a moment. Okay, and after that, wait for the reaction. Okay, and then get permission again. Is it okay to continue? If they said okay, yes, continue. If they said they want to take a break, that's fine. Take a break, and then we can come back and talk again. Okay, and then avoid excessive bluntness. Okay, don't go straight tell your father dead, your father brought in death. Okay, so you have to have, or we call it bertapis lah kalau cakap. Okay, and then avoid medical jargons. Okay, and then be honest and sensitive, be empathetic. Okay, mindful of emotional cues, see how they gonna react to you. Okay, and then check understanding, because sometimes you tell them this and this and this, they don't understand, they tell different thing to different family members. So you have to check the understanding, okay? And allow them to express the emotion, okay? And then be empathetic, be comfortable with silence, okay? And do not block emotional expression. For example, when they try to express themselves and suddenly you change story to different thing, okay? So you can, if they want to cry, that's fine, it's normal reaction for human beings, okay? And then you try to find positivity out of negativity of the situation. And this can be quite challenging to find positivity, right? Especially when somebody dead, right? So, but you know, if you can come up with something, that will be really good. Okay, and the last two sentence just apply to patient with cancer where we need to break the bad news. But in this situation, you don't have to know about this thing. Okay. Another thing is like, you know, when somebody really sick, okay, brought in like a head injury, not really responding to inotropes, okay, yeah, and then you said, you tell the family, okay, the patient's not responding to treatment, there's nothing much we medically can help the patient, the best thing now is best supportive care, and he probably, will die. The next question will be, when do you think, doctor? Okay, so when do you think? This is very, very difficult, very complex, right? Because even a very experienced physician will not be able to tell you exactly what time the patient's going to die, when, okay? Because it's very, very difficult. So in palliative care, we have what's so-called prognostic tools, okay? But the thing is, prognostic tools only apply for a period of time where you monitor or you observe the patient few days, few weeks, and then you can apply all the numerical values, and then you can tell when they're gonna, they're gonna go. But for acutely, somebody like a young man, gentleman, 19, had an accident, now they're not responding and they're gonna die, okay? So these tools cannot be applied to them, okay? So this is going to be very, very difficult, okay? But what do you call it? You will, medical student, once you become doctor, you will get this all the time from the family member. So how long did the patient have? Okay, so the problem is sometimes we do have a patient still around despite no urine output for a few days, okay, despite creatinines like 1000, urea like 60, 70, but this persistent, this still in the ward, okay, persistently hypertensive, blood pressure 50, 40, but they still lasted 2-3 days, okay, and some patients even have a dilated pupil for 2-3 days, okay. So it is very difficult. So what I want to tell you today, okay, avoid using numbers. Do not use numbers, okay? So what you can say, either short hours, short days, short weeks, months, or maybe few months, few weeks, few hours, okay? So because when you said short days, short hours, okay, it's very subjective. Okay, so the patient, the family cannot come back to you and say, oh, you told me it's only 3 hours left. Okay, and now it's more than 3 hours, patient's still around. Now it's like 1 day, patient's still around. Okay, so they come back to you. Okay, so avoid using numbers. Use days, weeks, short, long, okay, those kind of things. Okay, so it's very subjective. Okay, and they cannot really say anything to you, because when they come back to you, you can tell them that I said it's few hours. Okay, or I said it's short weeks, okay? So short weeks could be 1 week, could be 2 weeks, okay? Short hours could be 12 hours, could be 24 hours, right? So it's very subjective, okay? So avoid using numbers, okay? Now, another thing is what you can say, medical student, when you become a HO, okay? If you're afraid to say that the patient is dying, okay? You really want to tell the family, what you can say that, his condition is really worse, really concerning, really worrying me. Okay, so I will suggest for you to inform the rest of the family member. Okay, so when you say that with the body language, definitely the family can they can grasp what you're gonna try to tell them. Okay, so you just say that you're really concerned with the patient condition and you're really worried with the patient condition. Okay. Okay, another thing is like, when this patient like acutely, what do you call it, dying, they are in the terminal phase, okay, they can die anytime. The problem is when somebody has like a very complex symptoms and you need to use medication to control the symptoms. For example, they're very breathless, they have a severe pain, okay, so you need to use opioid. Now bear in mind, opioid does have a side effects, okay, such as respiratory depression, right? So you need to be very, very careful. So in this case, okay, you really have to sit down with the family, okay, tell them what you're going to use now is basically to control the symptoms, okay, and this medication does not, okay, prolong the survival, does not speed up the process of death, but basically the main objective now is for comfort measure. So I do have experience when somebody, a young guy who has a liver cancer, came into hospital with ruptured hematoma. He's in severe pain, okay, and the family really want the pain to be controlled, but we did sit down, thanks God, we sit down and we talk to the family, and as soon as we finished giving the morphine, patient passed away. So, but we sit down, we talk to the family, this is for comfort measure and doesn't kill the patient. So basically what we're doing now just to make sure that he's comfortable. He may die after the morphine. We told the family member and they accepted that. So we give the morphine and like few minutes after that, patient passed away. Okay, so spiritual care practicing can be challenging in ED. So when somebody dying, right, patient values, belief, as well as religious practice will not be possible to provide it in a very busy ED setting. So, and then family will not be able to be permitted with the patient, especially in resus area where there's another 3 patients down there. So I think a plan to revamp the ED to provide a place for patient, it's a very good way of dealing with this issue. And at this moment, worst come to worst, what we can do is just try to move the patient to observation ward, and if they can get to the general medical ward, will be more ideal. So thank you very much. Okay.
Thank you, Dr. Nur Azizan, for the insightful talk. Next up, we have a Q&A session. So I open the floor to anyone. Do you have any questions to our panel today? All right, so if there's no questions, I have a question, Doctor. Is it ethical for us clinicians to suggest family members to take the patient back home if we find them dying or terminally ill and there's nothing further we can do? Is it acceptable? Is it ethical for us to do so? Oh.
I'm in the hospital. Dr. Kassis. Okay. So your question whether it is ethical or not to bring the patient home, right? Okay. So depends on patient GOC, we call it goal of care. Okay. So what they really want, remember, patient-centered, they have a plan, they want what they really want, and if they think that, die at home is the best way for him, I would say we should respect that, okay, and try to provide whatever they needs. But if the discussion hasn't been made before and the family thinks, they really want to bring their loved one, the mom or dad, to die at home, and they will take full responsibility, I think we should let them take the family home. I think it's okay for me. Anyway, yeah. Okay. Dr. Kas, if you want to add something.
I think I agree with what Dr. Azizan said, but just now I mentioned about the concept of the good death. So it's depends on the family member and the culture perception about what is a good death. So even there's a guideline say this is what the item of good death, but sometimes the moment you met the family member, that's the request that they understand by the good death. So we need to support them and we help them how to bring their loved one to the family to the home. So to the ED is not ideal situation. They're very busy. Even in the ICU, the sound, and we have a limited time for visitation, right? So at home, maybe they are more like easy to manage. The family member, the neighbor can visit. So that's the perception about the good task. So we have to hormat what they want to the loved one, okay?
So I just want to add you something. You know, in this hospital, we do have what so-called terminal discharge in a patient that, you know, we think they're gonna go and they really want to be at home and they have a symptoms. During working hours, we can supply them with medication, provided that, you know, they have a support by the hospice. If they do not have a support, we will channel them to a private palliative physician. But if they can't afford the private palliative physician, we will try to get in contact, liaise with them, educate them how to control the symptoms. And if there's any issue, they can just let us know and call us back. Yep.
All right. Thank you, panel. Next up, we have a Kahoot session.
Hello. Saya akan tunjukkan QR code. Boleh scan Untuk doctors ada CPD point di sebelah kiri. Sebelah kanan untuk medical student untuk semua sekali. Untuk feedback form di sebelah kanan, sebelah kiri CPD point untuk doctors. Thank you.
Things due to the time limit, we can't proceed with the Kahoot session.